Dr. Lucas, for the very kind introduction and for the opportunity to be here to talk to you today about CAR T-cell therapies and how to improve the safety of these new therapies. This is my disclosure. And this is the menu du jour, which will talk about this new kind of immunotherapy called CAR T-cell therapy, which has really transformed the way we treat patients with high-risk and refractory B-cell and plasma cell malignancies. But despite this dramatic improvement, these therapies are associated with significant toxicities. And we'll discuss several toxicity mitigation strategies with a focus on interleukin-1 blockade with anakinra. And we will touch on some future research and directions. And so it became quite apparent early on during my training as a hematologist and oncologist that we had to do better in patients with chemorefractory B-cell malignancies, in particular those with refractory large B-cell lymphoma. On the left side of the slide, this is showing you a PET CT scan of a patient with refractory large B-cell lymphoma. You could see this patient had extensive nodal disease above and below the diaphragm. And this is historical data on the right side showing you the overall survival in this patient population from the SCHOLAR-1 study. And regardless of the timing of refractoriness, being a primary refractory or being refractory to subsequent line of therapy, overall outcomes were really dismal, with a median overall survival of 6 months and about 10% of patients alive in the long term. So clearly an unmet need in this high-risk population. And I became interested in, I was always very interested in the immune system, in immunology, and how we can potentially leverage the anti-tumor effects of the immune system using immune cells, in particular T cells. And the great-grandmother of all immune effector cell therapies is allogeneic hematopoietic cell transplantation, or allotransplant, that can leverage a powerful graft versus lymphoma effect, mainly mediated by T cells and NK cells, to get these malignancies under control. And we know that even in the advanced and relapsed setting, allotransplant is still sometimes the only potentially curative options in this patient population. And this is showing you some of the PFS and overall survival curves from the CIBMTR, the American registry data, and the right side data from Germany. You could see this plateau in the PFS curves and across a variety of lymphoid malignancies. The issue with allotransplant is that it's a complicated and toxic procedure, and the expected non-relapse mortality rates is between 10 to 20%, so only young and fit patients will be able to access allotransplant. So how can we redirect T cells to specific tumor antigens while not having to do an allotransplant? And this is showing you this cartoon, a normal T cell receptor on the left side and a CAR or chimeric antigen receptor on the right side of the slide. You could see they have a very, very different structure. The CAR can bind to the target antigen independently of HLA molecules using this binding domain that we called a single chain variable fragment. We have typically a spacer domain and a transmembrane domain, and then linked to this what I call the engines of the CAR, or the co-stimulatory domains, typically CD28 or 4-1BB, and the terminal domain, the CD3 zeta chains. How does it work in the clinic? How do we make CAR T cells? So we need to collect first the peripheral mononuclear cells from patients using a process called leukapheresis, and then we have to manufacture the cells. We typically would either ship them to an outside facility, or on some clinical trials we would make the cells on site. We can manufacture the T cells in bulk, or sometimes we can do a subset selection when we are interested in specific T cell subsets. So the gene modification typically involves a lenti or retroviral vector that will carry, so to speak, the CAR transgene. Once the T cells are transduced and they express the CAR, we can finally call them CAR T cells. We typically expand them, grow them ex vivo until we reach a target dose level, and we finally formulate them into an infusion product that we infuse back to the patient, typically after giving the patient a low course of low-intensity, low-dose chemotherapy that we call lymphodepletion chemotherapy. So once the CAR T cells are infused, they will, as I tell patients, swim around in the bloodstream. They will they are usually already quite activated by the ex vivo manufacturing process, and they undergo extensive proliferation, and they have the ability to traffic into the tissues and infiltrate into tumors. They will then infiltrate the tumor cells. They will attack or kill the tumor cells, and we discussed just a few minutes ago that it's not entirely clear exactly how they kill tumor cells, but we think they are using a lot of cytotoxic mechanism akin to normal T cells and CD8 T cells in particular, with coenzyme B, perforin release that will induce the apoptosis, probably some pyroptosis, and eventually the death of the cancer cells. And I wanted to briefly highlight that this long journey of bringing CAR T-cell therapy from the lab to the clinic actually was pioneered at our centers, both the Fred Hutch and the UW. And if we travel back in time, almost 20 years ago, 2004, the late Oliver Press and Brian Thiel led this, actually the first clinical trial of CAR T-cell therapy at the Fred Hutch with CD20 specific CAR T-cells. And later on, in 2012, the first patient was treated with a CD19 specific CAR T-cell product. There was work coming from Stan Riedell's lab, and that was translated into the clinic by Dr. Turtle and David Maloney. And this ended up becoming one of the largest academical trials of CAR T-cell therapy to date, with nearly 200 patients treated on this clinical trial. You could see in 2017 the first two CD19 CAR T-cell products becoming approved by the FDA, Tisagen Leclusol and Axicabtagene ciloleucel, or Axi-cell, for pediatric ALL and large B-cell lymphoma respectively. And in the middle, 2014, that's when as Dr. Lucas mentioned, when I first joined the Fred Hutch nearly 10 years ago already. Time flies, and after that we've seen an avalanche of approval from the FDA for a number of different B-cell malignancies, and now also for relapsed or refractory multiple myeloma, with two BCMA-targeted CAR T-cell products recently approved by the FDA. So this is the same data, simplified in table form, showing you that we now have a number of CAR T-cell products approved for large B-cell lymphoma, for the second line and beyond, for the third line and beyond in follicular lymphoma, for mantle cell lymphoma, for refractory B-ALL, and finally for multiple myeloma. And those therapies, this is just showing you the data in patients with large B-cell lymphoma in the relapsed refractory setting. CD19 CAR T-cells are extremely potent therapies with response rate as high as 80% and complete response rate from 50 to 60% across these different studies. Historically, approximately only 10% of patients would go into a complete response with a salvage regimen. And not only the response rates are high, but these responses can be very durable, and this is showing you a recent follow-up update from the pivotal trial ZUMA-1 using the CD19 CAR T-cell product Axi-cell, and that clearly demonstrated the curative potential of CD19 CAR T-cell therapy in the refractory setting, with a plateau in the overall survival and disease-specific survival curves. Well, still very far from 100%, but it's still a dramatic improvement compared to the historical data, as I first showed you, where less than 10% of patients were alive in the long term. So this is all and great, but CAR T-cell therapies are associated with some significant side effects. And today I will focus on two main toxicities: cytokine release syndrome, or CRS. Some people also call this cytokine storm, and another acronym called immune effector cell associated neurotoxicity syndrome, or ICANS. So this may be one thing to remember from my talk today, is what CRS and ICANS mean, and I will use these acronyms a lot during this presentation. There are other toxicities associated with CAR T-cell therapies, such as hematologic toxicity and cytopenia, oftentimes associated with infections, but I won't have the time today to talk about those. And before we jump into what CRS and ICANS look like, it took a little while for the field to actually agree on what really these toxicities were, how to diagnose them, and how to grade the severity of these toxicities. Finally was published in early 2019, the ASTCT consensus criteria, and this is showing you the criteria for CRS on the top table and the bottom table for neurotoxicity. for ICANS. You can see that fever has to be there to diagnose CRS. This is a hallmark. And the severity of the hypertension and the hypoxia will drive the grading of this, going from hypertension not requiring vasopressors to all the way grade 4 requiring multiple vasopressors. For hypoxia, for example, grade 2, low flow oxygen, grade 4, mechanical ventilation. ICANS, the grading of ICANS is more complicated. We have a score called the I-score that we use routinely in a clinic that will assess the cognitive skills of the patient. We'll ask patients to perform simple commands, to count backwards, to write a sentence. And we're scoring this from 0 to 10. We will assess the patient's level of consciousness, the absence of presence of seizures, some motor findings, and also in more severe cases, the evidence for elevated intracranial pressure, cerebral edema. So these CRS and ICANS are very, very common after CAR T-cell therapy. We consider up to 90% of patients will develop CRS, approximately 10% severe CRS. About 60% of patients will develop ICANS, and about a third of patients will develop severe ICANS. So those are very common toxicities. What does it look like when patients develop severe CRS? The typical picture is that of a severe capillary leak syndrome. You could see that patients spike very high fevers early on in the 40s or high 39s. They develop profound hypotension, hypoalbuminemia, hypoproteinemia, and a really very sharp increase in the weight as well. And we think this is because of some systemic endothelial dysfunction and activation. And this ties with the observation that these patients frequently developed significant consumptive coagulopathy or DIC-like picture. You could see prolonged PT, PTT, D-dimers, and a drop in the fibrinogen levels as well, both in patients with severe CRS and severe ICANS. And the really dreaded complication is these cases of fatal cerebral edemas or fatal neurologic toxicity, and we have reported on these cases. On the left side, this is a case in a patient who developed this severe diffuse cerebral edema. You could see on this MRI scan that the lateral ventricles are completely compressed by the surrounding edema. But these severe neurologic toxicities can also be quite heterogeneous in their MRI presentation, and this is another patient who developed this severe encephalopathy with this really patchy inflammation in the bilateral thalami, in the occipital lobes as well, that was further complicated by a large intraparenchymal hemorrhage. So not only these toxicities are common, they can be life-threatening, but they can also be prolonged. And this is work that is led by Dr. Albitar, who was an internal medicine resident at our center, and that data will be presented in a couple of weeks at ASH. We managed to identify some key factors that were associated with prolonged CRS and prolonged toxicities after CAR T-cell therapy. For example, having a lower platelet count, a prolonged PTT at baseline, and altered renal function were associated with a median time to resolution of toxicities of more than 2 weeks. So based on this, the field there has been a growing interest, and this has generated a lot of interest to better diagnose and better treat these CAR T-cell toxicities. This has been recently the topic of a How I Treat series published in Blood, and also some group efforts to try to narrow down and better define some subtypes of CAR T-cell toxicities, such as this immune effector cell-associated HLH-like syndrome. So trying to convince you that we should indeed improve the safety profile of CAR T-cell therapies. They are associated with morbidity and mortality. They will dramatically increase resource utilizations, and they will restrict these CAR T-cell therapies to large academic centers, and thereby limiting patient access. They can also limit our ability to dose escalate, increase the CAR T-cell dose when we are investigating novel construct, and we are oftentimes limited by these toxicities. And finally, our understanding of the actual biology of CAR T-cell toxicities remains quite limited. So I've tried to summarize some of the puzzle pieces that we know so far that are underlying these two toxicities of CRS and ICANS. So we think that the first event, of course, is the activation of the CAR T-cells when they engage our CAR receptor binding to the target antigen on the tumor cells, and that when the CAR T-cells are doing their job, and tumor cells will die, and one mechanism of cell death is pyroptosis, and there's been preclinical data demonstrating that this could be associated with CRS, and we know that this will lead to the release of these DAMs and some interleukin-1 beta, and that can consequently lead to other immune cells activation, and more specifically some myeloid cells and monocyte and macrophage activation. And we think that's really reflecting what we see in patients when they develop this HLH-like syndrome. So we have this very robust monocyte and sort of crosstalk between monocytes and the CAR T cells. And also an essential step here is the activation and injury of the endothelium. So not only the peripheral endothelium, so to speak, but also the blood-brain barrier. And the current conceptual model is that this disruption in the blood-brain barrier will lead to infiltration of the CNS by immune cells and by pro-inflammatory cytokines. There's also recent data suggesting that there could be some antigen-specific damage, in particular a group from Stanford who showed that CD19 can be expressed on brain mural cells that are surrounding the blood-brain barrier, and also evidence that BCMA is expressed in the basal ganglia, and there has been descriptions of patients who develop these hypokinetic Parkinson-like presentations after BCMA CAR T-cell therapy. So how do we treat CAR T-cell therapy? The mainstay is cytokine blockade. We use very frequently in the clinic tocilizumab, an antibody targeting the anti-IL-6 receptor, occasionally cetuximab, and frequently associated with high-dose corticosteroids, typically given IV, such as dexamethasone and methylprednisolone. So a really broad effect on CAR T cells and on other immune cells in the endothelium. So far, we have not been very successful at preventing these toxicities. And I'm showing you here data from a clinical trial, the ZUMA-1 trial, that tested a very broadly used CAR T-cell product called Axi-cell. And we could see that in the first row, this is the initial cohorts in the trial, and the investigators had an additional sub-cohort where they used early corticosteroids for, basically the steroids would be started for a lower grade of toxicity. You can see that the overall rate of CRS and ICANS was very comparable. There was perhaps a modest decrease in the incidence of severe toxicities. So they try to do better, and they try to give prophylactic tocilizumab or prophylactic corticosteroids, so every single patient would get it. And it didn't work very well either. We've seen maybe a modest reduction in the rates of CRS, very comparable rates of ICANS, both all-grade ICANS and severe ICANS. So there's been something the field has been struggling for a while, and also with a somewhat limited understanding of the biology. The question is really, can we identify some targetable pathways that would reduce toxicity, but of course without impairing efficacy? Because we are giving patients these CAR T-cells for a good cause. They have these high-risk refractory blood cancers. We don't want to impair that, yet we need to be better at improving the safety profile. And we know there's a great overlap between efficacy, the mechanisms of efficacy and toxicity. Of course, we think CAR T-cell activation is very central. Also, potentially the target antigen expression, the amount of systemic inflammation, the disease burden. So I wanted to share with you some preliminary data, and this is done with the help of two of our talented hem-onc fellows, Dr. Liang and Dr. Huang, when we looked at patients treated on investigator-initiated clinical trials at our centers targeting CD19. And we looked at a number of characteristics, patient, disease characteristics, T-cell characteristics, and one part is not showing here, some manufacturing characteristics of the CAR T-cells as well, and of course some of the in vivo CAR T-cell kinetics, both the peak and the CAR T-cell persistence in vivo in these patients. So we use logistic regression to model that, and I spent just a second to explain this complicated figure. This is what we call a volcano plot. You may have seen this before. And each dot is showing you the result from one regression model. These are just multiple univariate regression models. On the x-axis, this is the odds ratio, which can quantify the effect size. And on the y-axis, this is the p-value that is transformed into what we call an S-value, of surprise value. The higher this value on the y-axis, the more surprising the data is under the null hypothesis. In other words, the smaller the p-value. And what we could see here quite overwhelmingly when we try to model efficacy, day 28 response, that everything that's popping up are related to the in vivo CAR T-cell kinetics. So we have the peak CD3, peak CD8, peak CD4, and also the AUC. So you can look at it in multiple ways, but critical, the CAR T-cell in vivo expansion really drives the efficacy of this. We also have the disease burden, as expected. The higher the disease burden, the lower the odds of response, as expected. And unfortunately, when we look at severe toxicities, grade 3 ICANS, the same factors, most of these factors are also associated with toxicity. We see the CD3 AUC, CD8 CAR T-cell AUC, and so on. So this is not extremely surprising, and we wanted to take a deeper dive and try to interrogate the immune proteome using Luminex and looking at a number of different analytes, and we were interested in some cytokines, some growth factors, some chemokines, some number of adhesion molecules that could be implicated in these toxicities. And when we did that, so we looked at them longitudinally at multiple time points before and after CAR T-cell, we kind of once again saw that CAR T-cell activation and in vivo activation is critical both for response and also for toxicity. And this is showing you in these blue squares, turquoise, not squares, circles, that soluble IL-2 receptor alpha levels were strongly associated with both the efficacy and the toxicity. And as you know, soluble IL-2 receptor alpha is also called CD25. This is a key T-cell activation marker. We also found some other interesting association that FLT3 ligand, higher FLT3 ligand was actually strongly associated with lower disease burden and better response rate. We found also that, as one would expect, peak interferon gamma was associated with toxicities. So, of course, this is in a relatively small number of patients, and this is using Luminex, and we know that the specificity and sensitivity of Luminex will start to deteriorate as we start to multiplex more and more, especially if we go up to 30, 40 and more analytes. And a lot of these apical cytokines and chemokines may be present at very low concentrations in the low picogram range, and we may not be able to capture these important cytokines that may be just lost in the noise of the assay. So there's clearly a need for better multiplex platforms with better sensitivity and specificity. There's a number of platforms out there. I've listed a few of them. The Olink, that I will talk more in a few minutes, Quanterix, and the MSD platform. And more specifically, we were very interested in interleukin-1s, interleukin-1 alpha and beta, that we know is a master regulator of inflammation. And this is showing you in this figure very simplistically, because the biology of interleukin-1s are very complicated, but that interestingly interleukin-1 alpha is at steady state constitutively present in its active form and is typically released by dead cells. In contrast, interleukin-1 beta has to be, there's a proteolytic cleavage from a precursor form that is inactive, and that happens upon activation typically of monocytes and macrophages upon a specific stimulus. So they have a very different biology. They all share the same receptor, interleukin-1 receptor 1, and that's a targetable pathway. We can block this with anakinra. And this has been involved in a number of different human diseases, some autoimmune diseases, rheumatoid arthritis, some cryopyrinopathies, Schnitzler disease, Still's disease, some things like gout, sepsis, HLH, and others. So we can block this pathway with anakinra. There's other drugs as well that can block interleukin-1, but we'll focus on anakinra today. This is not an antibody. This is a recombinant protein, a non-glycosylated form of the human interleukin-1 receptor antagonist. It is already FDA approved for a number of indications, mainly for moderate to severe rheumatoid arthritis and for a group of these cryopyrinopathies called NOMIDs. There's a lot of off-label clinical experience using anakinra to treat refractory HLH. So when we specifically look at interleukin-1 beta in our data set using Luminex, you could see that the data looks terrible. There's basically no variance. Everything is clustered at the background level of detection of the assay in this low picogram range here. So we're interested in taking a deeper look at this using a more sensitive platform, and we collaborated with our neighbors from ISB in South Lake Union who had access to this Olink platform. And this platform is using this licensed proximity extension assay technology that is based on these pairs of oligonucleotide and antibody. And when these two pairs meet together and they are reacting to the same protein, they will hybridize, and the signal, this amplicon, can be amplified by NGS or qPCR, which allow for significantly better performance when multiplexing. So we looked at, did a pilot study looking at a small number of patients who receives a commercial CAR T-cell product. These patients had lymphoma. And you could see that, although we are at very low levels, we are really flirting with a lower level of quantitation of the assay, there was a trend towards higher levels of interleukin-1 beta in the plasma of patients who developed these toxicities. And other people have also shown that. This is data from Penn in the pediatric population of ALL patients treated with CAR T-cells. You could see this higher peak of interleukin-1 beta in patients who developed ICANS. And when we went back and looked at data from Mike Jensen's lab, this is published quite a few years ago now in 2018 in a non-human primate model of CAR-related ICANS, they also measured higher levels and a significant increase of the levels of interleukin-1 beta, both in the serum and in the CSF of the monkeys developing hematologic toxicity. So this led a lot of people in the field to try to use anakinra preclinically. And these are two papers that came out in actually the same issue of Nature Medicine. One using from Italy, from Milan, from the Bondenza lab, using a humanized SGM3 models, where they found that interleukin-1 was produced by human monocytes, was produced very early on, before IL-6 production, and that they could block interleukin-1 using anakinra and preventing CRS and neurologic toxicity in the mice. In contrast, when they used tocilizumab to block IL-6, the mice still developed ICANS. There was data also from the Michel Sadelin's lab in New York, at Memorial Sloan Kettering, using a skid-beige mouse model, where they could also prevent CRS using anakinra. Interesting data from the NIH, where they used a model of HLH, which is a perforin-deficient mouse model, a syngeneic mouse model treated with CD19 CAR T-cells, and they found that they could improve the survival of the mice using anakinra and decrease the serum levels of some pro-inflammatory cytokines. And they were particularly interested in that because they had a lot of issues on a clinical trial in children with leukemia in ALL treated with CD22 CAR T-cells, and these children developed this cytokine storm first, but then they developed this HLH MAS type picture with liver function test abnormalities, a secondary rise in the ferritin, and this could be successfully treated with anakinra as well. So all this put together, we thought that this interleukin-1 receptor pathway was a promising target to try to reduce toxicity without impairing efficacy. So this motivated us to design a pilot study using prophylactic anakinra to prevent toxicities after CAR T-cell therapy. So this is showing you the study design, and this is typical as standard of care for CAR T-cell patients. We collect the cells, leukapheresis, we generate the CAR T-cells, then we give them 3 days of lymphodepletion chemotherapy. And anakinra was planned to be started on the day of CAR T-cell infusion, here with Lysocell, which is an FDA-approved product, at 200 milligrams per day, given once a day subcutaneously for 14 days, so from day 0 through day 13. This is showing you the consort diagram at the time. So this is data This is work that is led by Dr. Liang that we hope to present at the ASTCT meeting next year. At this preliminary analysis, we had screened 18 patients. 15 had received the CAR T-cells in all doses of anakinra. All of these 15 were evaluable for toxicity assessment, and 12 of them were evaluable for disease response assessment. This was the median age in this population was 68. You could see that 3 patients identified as non-white, 1 patient identified as Hispanic or Latino. This was primarily patients with diffuse large B-cell lymphoma, NOS, heavily pretreated, 3 lines of prior therapies. Interestingly, 20% had active CNS involvement prior to the start of treatment, and about a third of patients had bulky disease prior to treatment as well. So the good news is that giving these patients prophylactic anakinra was very safe, and all 15 patients received the treatment as planned without dose adjustment or any interruption. There was no AEs related to anakinra treatment, in particular no injection site reactions. There were 2 infections diagnosed during anakinra treatment. Both were mild and rapidly resolving. Now, some of the key endpoints here, looking at the rates of toxicities, we found that we observed low rates of toxicities overall, with only 53% of patients developing any grade CRS. 1 patient developed severe grade 3 CRS. We did not observe severe ICANS above grade 4 or above. All cases were grade 3 per ASTCT criteria, so 20% of patients. These toxicities were short-lived. We could see that the median duration of fever was 2.5 days. 27% of patients required IV fluid boluses. 1 patient required vasopressors. No patient developed hypoxia. The duration of ICANS was 9 days. No patients had depressed level of consciousness. None developed seizures, and 3 developed delirium. 1 expressive aphasia. 1 patient tremor, and 1 patient allodynia. A low percentage of patients required some cytokine blockade or corticosteroids, 20% tocilizumab, 27% dexamethasone, 1 patient high-dose methylprednisolone. About a majority of patients did require hospitalizations. I did not mention, but typically these CAR T-cells are given outpatient, and we try to keep patients outpatient unless they have toxicity. So 67% end up in the hospital, but the hospitalization duration was short, 6 days on average. 1 patient did require ICU admission that was brief for less than 24 hours. Importantly, we were very interested in maintaining the anti-tumor effects. We did observe some comparable response rate at 67% and complete response rate 42%. And in line with this, we did measure a very robust in vivo expansion of the CAR T-cells in these patients receiving anakinra that was actually higher than what had been described on the pivotal clinical trial, with over 100,000 transgene copy per microgram of DNA measured at the peak expansion. And at the last follow-up, we had persistence of CAR T-cells in all patients with available data by PCR. So that's great and interesting. Of course, this was not a randomized study, and with all the limitation of retrospective comparisons, we attempted to compare these findings to patients who received the same CAR T-cells outside of the clinical trial per standard of care at our center. And this is showing you the basic patient and disease characteristics. These patients were quite comparable in terms of age, sex, and the type of disease. We did notice a higher percentage of patients with active CNS involvement induced on the anakinra trial, and also higher levels of systemic inflammation in patients in the anakinra trial, as reflected by higher levels of CRP and IL-6 prior to lymphodepletion. When we compared these 2 cohorts, we found that there was numerically the percentage of the incidence of all-grade CRS was lower with anakinra at 53% compared to 69% in patients who did not receive anakinra. The overall incidence of ICANS was very comparable in the 2 groups, 27% compared to 28%. To try to dive a little bit deeper into the effect on the systemic inflammation that we can measure in these patients, we found that the time to resolution of fever seemed faster in patients receiving anakinra, as shown here in this longitudinal data. This is showing you the violin plots for each day, taking the peak temperature for each day after CAR T-cell infusion. And this was also seen when we looked at the CRP levels over time. We could see that faster normalization of the CRP in patients receiving anakinra compared to the CAR T-cells alone. So this is the summary of this pilot study. We found that it was very feasible, it was completely safe, with lower rates of CRS compared to our historical control, faster resolution of systemic inflammation, but somewhat disappointing comparable rates of ICANS, and we did not meet the primary endpoint that was based on the rates of CRS. Compared to the clinical trial that used the same CAR T-cells, we actually saw higher rates of CRS with comparable rates of ICANS, and reassuringly comparable to superior in vivo CAR T-cell expansion. So, in the meanwhile, other centers had the same idea as us and also conducting some small studies using anakinra, albeit using different types of CAR T-cells, and most of the studies use axi cells. So there's data from Memorial Sloan Kettering, Mass Gen, Dana-Farber, and MD Anderson. And the data is a little bit all over the place with some discrepancies across the studies, but overall the most promising and encouraging data came from MSK with a remarkably low rate of ICANS at only 19% and 10% of severe ICANS, and despite having very high anti-tumor efficacy. So I thought that was interesting, and we went back and kind of put all these different studies together to try to find what were the similarities, but also what distinguished the studies. And we found that all the studies used about the same dose of anakinra initially, 100 to 200 milligram. They all used the subcutaneous route. But one difference in the MSK cohort is that they allowed to up-titrate the dose of anakinra in patients with breakthrough toxicities. And I thought that was very interesting because this is not really in the textbooks, but for physicians who treat patients with HLH or Castleman's disease, we know that there's rarely a one dose fits all for these patients. And oftentimes we have to up-titrate to get that inflammation, get that HLH under control. So I thought that was a very good idea to try to tailor the anakinra dose to the symptoms, to the clinical symptoms presented by the patients. We also know, if we go back to some older literature, that anakinra is a sort of chunky molecule with low penetration into the CSF. It does penetrate into the CSF, but to achieve neuroprotective concentrations, typically extremely high doses have to be given. And this was shown in some preclinical models and in humans that we have to give it IV, and typically at doses at around 2 milligrams per kilo per hour or even higher. And we also know that anakinra has been shown to be very safe even at very high doses, and it's been actually escalated to doses up to 10 milligrams per kilo per hour on some clinical trials in patients with subarachnoid hemorrhage. We know that higher anakinra doses are commonly used off-label to treat patients with refractory HLH. So based on that, a lot of people in the field of CAR T-cell therapy started to use anakinra off-label to treat patients with refractory CRS in ICANS. And this was work led by Dr. Gazzo, who used to be a postdoc in our group, who conducted this multi-center international retrospective analysis. We really wanted to take a snapshot at how people were using anakinra in CAR T-cell patients. And we found 43 patients with B-cell plasma cell malignancies treated at 9 institutions. There were 7 centers in Spain and 2 centers in the US. And without going into too much details, we found that when we looked at the dose of anakinra that was chosen by the physicians, it looked like a bimodal distribution where we had most patients receiving the lower dose of anakinra, which is the RA dose at 100 to 200 milligram flat dose given subcutaneously, or 8 to 10 milligram per kilo per day given IV, and is typically given Q8 hours. So, and when we stratified patients, categorizing as either low dose or high dose, we found that the time to toxicity resolution was significantly faster in patients who received high dose anakinra, and also the treatment-related mortality was significantly lower in patients who receive high dose anakinra. Based on the PK data that is known, this is probably better in patients that develop this extremely robust systemic inflammation with very strong T-cell monocytic activation. And we know we can achieve Cmax that are approximately, we'd say 1.5 order of magnitude using the IV route compared to the sub-Q. So this motivated us to go back to our founding partner and ask if we could do a small expansion cohort and treat patients with IV anakinra instead of sub-Q anakinra. And also, and I think quite critically, to allow up titration of anakinra in case of breakthrough toxicities. So we would have a two-step dose escalation algorithm. We can increase first to 8 milligram per kilo per day, and then to 1 milligram per kilo per hour continuous IV for 72 hours. Additionally, we'd like to take a deeper dive into the immunomodulatory effects of anakinra to better understand the biology of CRS and ICANS. And we have some very exciting collaborations with Evan Newell, with Stan Riddell, Sylvain Simon, to try to look at, do what they call deep immune profiling at a single cell level using CyTOF. We also want to look at use this multiplex Olink proteomic platform to better understand if we can identify some different cytokine signatures in these patients. And finally, we also want to look at the function of CAR T-cells in vivo and the kinetics of CAR T-cells in patients who receive anakinra. Okay, so I spent a lot of time talking about anakinra, but there's interleukin-1 blockade. There's other angles to this and other strategies that have been studied. There are ways to make the CAR T-cells safer just by optimizing the manufacturing of the CAR T-cells. And this is fundamentally what was done for Lysocell, which is one of the CAR T-cell products that for which we actually designed a prototype at the Fred Hutch. And by simply optimizing the manufacturing and potentially generating less differentiated CAR T-cells, we are able to improve the safety profile. We can optimize the CAR design. We can also try to tweak or tailor the dose of CAR T-cells based on the amount of disease that the patient has, and that's been done a lot in ALL patients based on the amount of tumor they have in the bone marrow. We can do an approach called split dosing when we fractionate the dose of CAR T-cells. Of course, there's a number of inflammatory pathways that one could consider targeting. I'm looking forward to some exciting data that will be presented in a few weeks at ASH using itacitinib, which is a JAK1 inhibitor, data presented by Mathieu Frigo from Mass Gen and Dana-Farber. And this is a small randomized phase 2 studies with promising results. There has been other strategies to try to block GM-CSF, to use dasatinib, ibrutinib. We have published on this. Interferon gamma blockade, we know that this drug, emapalumab, is FDA approved for HLH. And finally, we just published a few days ago, actually, in Blood, an approach aimed at endothelial protection using the fibrotide, which is used, as you know, in the post-transplant, post-allotransplant setting, with quite modest results in terms of reduction of toxicities, unfortunately. So some take-home messages. CAR T-cell therapies have really transformed the way we treat patients with high-risk or refractory B-cell and plasma cell malignancies, but they remain limited by significant toxicities. They are potentially life-threatening, they are common, they can be prolonged. They will cause increased cost of care, resource utilization, and eventually limit patient access to these potentially life-saving therapies. Unfortunately, the current prophylactic strategies do not work very well. And a lot of researchers, such as myself, are working on trying to optimize this. Have discussed with you the use of IV anakinra with the option to up-titrate. There is this interesting data using JAK1 inhibition. But I think fundamentally we need to better understand the underlying biology. I'm working on developing in collaboration with Anthony Ronvaux at our center a humanized mouse model of CAR T-cell toxicities using his famous Mr. G model. And I wanted to very briefly share another project that we have been working on, and the study concept will be presented at ASH in a couple of weeks, to try to use a novel strategy aimed at endothelial protection using a recombinant interferon beta-1a. And we know that interferon beta-1a is associated with improved maintenance of the endothelium, and this is mediated by the upregulation of an enzyme called CD73 that can protect the endothelium, protect the blood-brain barrier, and that could potentially be useful and efficacious to prevent neurologic toxicity specifically. So we are working with a small company called Ferren Pharmaceuticals to try to push this into the clinic. And with this, I will say thank you very much for your attention. There's a lot of some current and past mentors and collaborators. I'd like to acknowledge the work and the help for some wonderful trainees, particularly Dr. Liang, Dr. Huang, Dr. Albitar, and the statistical support from Dr. Wu. I would like to thank our Fred Hutch Immunotherapy Clinic and our Integrated Immunotherapy Research Center at the Fred Hutch, and our funding support as well. Thank you very much. Oops. Please, so do you need a microphone?
No, that was great, thank you. I think if you can repeat the question for those on Zoom.
Will do.
That are here. So I have two questions. One, the first is related to the hypothesis that anakinra dosing may not be sufficient for the typical anakinra dosing. And I wonder if there's any biomarker that you can use of IL-1 receptor activity, like a transcriptional signature or anything like that, to sort of test that hypothesis, right? To say, are these doses suboptimal for actually inhibiting something that should be IL-1 dependent?
Yes, so the question is, are there sort of PD markers of anakinra activity? And so we can try to understand if there could be a dose-dependent efficacy. So it's a good question. There's actually no really validated PD marker for anakinra, and if you look at most of the studies, they look very basic markers of inflammation, CRP, IL-6, and some of them being either upstream or downstream. So nothing that would be very specific to interleukin-1 receptor signaling, and I know there's a... So one idea when we look at CyTOF potentially could, because the CyTOF panel that Sylvain has designed, we can look at intracellular signaling. So there's a number of stats that we can look at, but some of them may not be specific to interleukin-1 receptor. There is other kinase, IRAC, and a lot of other kinases that are being recruited by the interleukin-1 receptor. So it's not straightforward. Some of these antibodies actually don't work for CyTOF. So it's quite challenging to really look at that. Some people have used markers of monocyte activation, and it's phospho-STAT3, for example, specifically in monocytes and macrophages could be maybe a bit of a PD marker for anakinra. And if we saw that there is this, by increasing the dose, we do see reduced percentage of monocytes expressing phospho-STAT3, and so that would maybe be an indication of that. But it's not straightforward.
And then my second question is regarding the cell death and how that might contribute to the toxicities. And there's some data that pyrotosis releases, particularly the plasma membrane rupture part of it, that final step releases procoagulant factors. And I'm wondering if it's what the current hypothesis is regarding the coagulopathy that's seen in this setting, and whether that could be related.
Yeah, it's a good question. I think the initial thought, if we go back to my prior mentor Cameron Turtles and his work, that there's this cancer discovery paper, I think 2017. There's in supplementary material you could find this figure when they try to show what would be the mechanism that would explain this endothelial injury. I think it was felt to be mainly cytokine mediated, TNF-alpha, interleukin-6. And then they felt that it could be a sort of vicious circle with activation of pericytes and the endothelium itself producing other pro-inflammatory cytokine. And then and what they found at the time also is that it could start looking like a TMA-like picture with cleavage of von Willebrand factors and some microthrombi, and that's something in some of the patients who developed fatal ICANS, they found these features that looked a little bit like PTT or TMA. But really, we don't know exactly what's causing this endothelial injury. I think it's probably some cytokines. It's an easy answer. Is there a key pivotal cytokine that initiates this process? Could it be interleukin-1 beta? There's suggestion from these imperfect preclinical models, but in humans it's unclear. Sure.
Could you please go to the next slide that has the QR code?
Sure, I will do this. Yeah, please. Yeah.
So the product that you're making is somewhat heterogeneous with different T-cell subsets. Have you looked to see whether or not, any T-cells are more adapt to killing the tumor and others are more likely to cause toxicity, or do the two go together?
It's a great question. The question is, could the heterogeneity of the CAR product be associated with outcomes and toxicity, and there is a way to tweak the composition of the product, the T-cell subsets, to improve the therapeutic index of CAR T-cell therapy? And that's great. So actually, Stan Riedel thought of that early on, and if you go back to some of his work published in Leukemia, I think 2017, Sommermeyer was the first author. They tried different ratio of CD8 and CD4s, and they went a little bit more granularly, different naive or memory subset of CD8s. And the best combination in the mouse, in the Raji mouse model, was to use a 1-to-1 ratio of CD8 central memory T cells and bulk CD4s. And unfortunately, in humans, it's challenging to do so because many of these patients are very lymphopenic, and this CD8 central memory has such low levels that it's kind of hard to manufacture the product. The product in the clinical trial that I showed used a 1-to-1 CD8 to CD4 ratio, which is the product called Lysocell, and that's what they used at the start of manufacturing. I didn't go into the details of manufacturing, but each subset is manufactured in parallel. But within this, there is still some heterogeneity and some subsets. And even within patients, across patients, some patients have also different percentage of naive to memory subsets, different CD8, CD4 ratios at baseline. But with Lysocell at the end, they get the same ratio, 1-to-1 ratio of CD8 to CD4 CAR T cells, which is not the case with other CAR T cell products.
Are there other differences between the CAR products that explain some of the variability in the outcome, and what are those differences?
So the question is, are there differences in the CAR T cells or CAR T cell products that may explain some of the differences that we see in outcomes, in particular differences in toxicities? And great question, and the answer is yes. I didn't have time to really discuss this today, but we've actually shown that the product type, in particular receiving a CD28 co-stimulated CAR T cell product, such as axi-cell or brexi-cell, was independently associated with more toxicity, but also more efficacy in a retrospective analysis. So we have data that we'll be showing at ASH when we compare Lysocell to axi-cell in the non-clinical trial settings. And we, again, even when we adjust for a number of confounders, the product that has the CD28 co-stimulatory domain is significantly associated with more toxicities with comparable efficacy compared to Lysocell. So that's good. But we think the CD8 co-stimulatory domain, when we look at the kinetics of expansion of these cells in vivo, it seems to be a bit more abrupt. They tend to expand faster, maybe earlier, and they, based on some data, they may not persist as long as well. And we think that could be related to that difference in the co-stimulatory domain. There's many other things that can also influence the CAR that I didn't go into that, but some people have tweaked, for example, the transmembrane domain. That's not even really signaling or doing, but just by changing this transmembrane domain, they were able to actually change the kinetics of activation and cytokine release. So many different tweaks in the CAR construct itself can change that. So, and we can talk more about, there's a lot of subtle differences across products, but a lot of people think the co-stimulatory domain is driving that difference.
So we have a question from our online audience. Could the uptitration of CAR T-cell therapy itself reduce undesirable CRS without losing efficacy?
So I'm not sure I understand the question, but the question was, does uptitrating the CAR T-cell dose?
Right, could that actually reduce the CRS?
So what most people have seen, and it's not a one-to-one correlation, but typically both efficacy and toxicity are pretty, depending on what product you use, but when you use defined composition products, such as the product that we use in our clinical trials or Lysocell, there tends to be a relationship where higher dose, higher toxicity. So I'm not sure how that would work, but people have done, if you have a lower disease burden, you are inclined to give a higher dose, and you try to adjust, for example, a patient with ALL with very low disease burden, is safe to give a higher dose. But if you have a lot of disease, 90% blast in the bone marrow, typically we would dose adjust. And on one of the clinical trials, I didn't show you this data, we actually had separate cohorts. One was a high marrow burden cohort, and we had a low marrow burden cohort with a distinct dose escalation schema in each cohort. So, but typically, a higher dose is associated with more toxicity. Okay. To Lucas? Sure.
So this is more a general question related to the CRS score. With hypoxemia being one of the score components, has the field started to look at differences between people with lighter and darker skin, given the recent awareness that hypoxemia might be falsely or might be occult hypoxemia in individuals with darker pigmented skin?
Yeah, it's great question. There has been work looking at indicators of disparities just to access CAR T-cell therapy, factors, what were people participating in clinical trials, was the population diverse in the pivotal clinical trials, but I don't think there has been studies looking specifically at pulse oximetry in non-white patients and patients with the darker skins, I don't think, but that's a great point. I think we should look at it. Thank you. Thank you again.